Now it's the turn for Professor Atef Elbahry, a professor of vascular medicine and the vice president for the Egyptian Atherosclerosis Society, and he will address in his presentation now on his talk for us on peripheral arterial disease and diabetes, giving us important tips and tricks. Professor Atef, the floor is yours.
Thank you very much, Professor Mohammed, for your introduction. The peripheral arterial disease in diabetes is a very important subject, which we should take care of it. There were at least 202 million individuals with peripheral arterial disease worldwide, and the peripheral arterial disease is more prevalent than many leading diseases, as we see, more than cancer, congestive heart failure, and stroke. And if we look here for the primary care office settings, in the partner study showed the prevalence of peripheral arterial disease in primary care clinics was almost 30% in high-risk patients. If you look for the common risk factors, as we see, total cholesterol more than 10 milligram per deciliter, hypertension, smoking, and diabetes, we will find that diabetes is the greater risk affecting the peripheral arterial disease, and patients with diabetes are at 4 times higher risk of developing symptomatic peripheral arterial disease versus the general population. Diabetes increases the risk of peripheral arterial disease, as we see with impaired glucose tolerance and in a patient with over diabetes. If compared to the normal glucose tolerance, we find that the patients who have diabetes have the higher prevalence of peripheral arterial disease. 1 in 3 people over age 50 who have diabetes also have peripheral arterial disease, and 60% of non-traumatic lower limb amputations for people over 20 are those with diabetes. If you look for the 10-year risk of atherothrombotic events in patients with vascular disease, we will find as a tip that there is increased risk of myocardial infarction 2 to 4-fold, includes only fatal myocardial infarction and other cardiovascular deaths, and there is an increased risk of stroke by 2 to 3-fold, including the transient ischemic attack. And for the survivor of patients with peripheral arterial disease, the life expectancy reduced 10 years in patients with peripheral arterial disease. The mortality rate is about 25% at 5 years, and 50% at 10 years, and 75% at 15 years. As years with the peripheral arterial disease is increasing, the mortality is very high and is folded. In the study of partner study detecting the peripheral arterial disease with symptoms, they found that 90% of patients did not have classic intermittent claudication symptoms. The authors concluded that up to 90% of patients with peripheral arterial disease would be missed if healthcare providers relied solely on the classic symptoms of intermittent claudication, and healthcare providers should also routinely inquire about the atypical symptoms. A very important tip: we can find the peripheral arterial disease blockage and symptoms by dividing the lower trunk arterial system into 3 parts. If the aorta and the iliac artery are blocked, we will find the location of cramps and pain at the buttocks, at the hip and the thigh. If the femoral artery is blocked, the thigh and the calf. And if the popliteal artery and tibial artery are occluded, the calf and the ankle and foot having the cramps and pain. It's very simple for every practitioner to palpate the dorsalis pedis artery and to palpate the posterior tibial artery and to palpate the popliteal fossa artery to detect the pulse of these arteries. And measuring the ankle brachial index is very important by using the right arm systolic blood pressure measurement, right ankle systolic blood pressure, left arm systolic pressure, and left ankle systolic pressure, and putting them in an equation: higher right ankle pressure over higher arm pressure will get the right ankle breaker index, and the same as the left. And the guidelines have interpreting the ankle breaker index to show that the ABI from 1 to 1.39 is normal, from 0 to 91 to 0.99 is borderline, and from 0.41 to 0.90 mid to moderate disease, less than 0.40 is severe disease, more than 1.40 is non-compressible in diabetes and chronic kidney disease. And the ABI and the American College of Cardiology, American Heart Association guidelines put the ABI as a level of evidence. If we have other testing methods like the pulse volume recording or using the ultrasound and using the CTA and MRA. There is an important classification for the stages, which is called the Rutherford classification, or the Fontaine classification. The Rutherford classification makes the stage and the clinical symptoms in degrees. 0, asymptomatic. 1, mild claudication, and 2, moderate claudication. 3, severe claudication. If the patient have 4, it means he have wrist pain, ischemia, and 5, he have ulcer and loss of tissue. If 6, advanced ulcer and gangrene. And we should know that the critical limb ischemia amputation rate is 10 to 40%, and the 3 times MI, stroke, and vascular death. The acute limb ischemia are 5 P's. The patient has pain and pulselessness and pallor and paresthesia and paralysis. The clinical presentation of the peripheral arterial disease is very important. We can find here that 50% of patients are asymptomatic, and about 33% of the patients are atypical link being functionally limited, and 15% have classical typical claudication. 1% to 2% have critical limb ischemia, which is very dangerous. We can find here that all those patients with 50% can turn in time to the others. From this slide, we see the 5-year outcomes here. The limb morbidity, as we see, the stable claudication can be increased to 70 to 80%. Worsening of claudication can increase to 10 to 20%. The critical limb ischemia can be from 1 to 2%, leading to amputation. On the cardiovascular mortality, you can find the non-fatal cardiovascular event, MI or stroke, will increase to 20%. Mortality increase to 15 to 30% due to cardiovascular causes, which is 75%, and non-cardiovascular causes is 25%. Here a question, very important. Is peripheral arterial disease is atherosclerosis or thrombosis? We know that diabetes have here an effect on the peripheral arterial disease. We can see here the advanced glycation in the products, oxidative stress, inflammation, oxidized LDL. These are working on the downregulation of vasodilators such as nitric oxide and the prostacyclin, upregulation of vasoconstrictors, apoptosis of endothelial cells, leading to atherosclerosis. And on the other side, activation of the coagulation, abnormal platelet activation, and rupture of the plaques, leading to atherothrombosis. It means here that peripheral arterial disease is a component of atherosclerosis plus atherothrombosis. Diabetes is a prothrombotic state because impaired platelet dysfunction happened with increasing adhesion, aggregation, and activation, impaired fibrinolysis, and increase the PIA alpha-2 antiplasmin and decrease the TBA. Impaired coagulation was increasing fibrinogen, fulvilevrand factor, the thrombin, and factor 7, and factor 8, 82, and the sulfated heparins, with endothelial dysfunction in the form of increased adhesion molecules, leukocyte endothelial interaction, and oxidative stress, impaired the vasodilatation and endothelial degeneration. All are sharing to cause the thrombosis in the peripheral arteries. And this is a very important tip for this slide. Many studies for the critical ischemia and the most serious complication of PED, and the studies from 95 patients, 121 amputation specimens were examined, and 75 patients have critical link ischemia. They found that this is not a stenosis, this is a thrombosis. The multi-layer, the sequential thrombosis posterior tibial artery, and the occlusive thrombosis of anterior tibial artery, and rupture fibroatheroma lac with a thrombus. So thrombosis is the main cause of the peripheral arterial disease. This slide is very important. This is the humeral artery, and this is the infra. We can find here, this is atherosclerotic plaque, medial calcification, and acute thrombi, and this is a chronic thrombi which includes the arteries. They find that the femoral artery and the gluteal artery, the infragluteal arteries with more than 70% luminal stenosis. We can find here about 73 of the arteries, presence of thrombi contributed to the luminal stenosis. About 33 of the arteries had thrombi associated with significant atherosclerosis. In the remaining 67% of arteries, thrombotic occlusion was associated with insignificant atherosclerosis. In the minority here, about 25% of the arteries show stenosis was due to significant atherosclerosis without thrombi. In the minority here, about less than 2% luminal compromise was due to revascularization resulting from the previous operation. So the 73% of the arteries presence of thrombi contributed to luminal stenosis, and this is evidence-based medicine to prove that the limb ischemia in diabetics are due to thrombosis. In the guidelines recently, last year, how to prevent the cardiovascular disease in patients with diabetes mellitus. First of all, lipid control. The statins remain standard lipid lowering and should be given by high intensity statin. Ezetimibe can be added, or PCSK9 inhibitor. Alone or with a statin can improve cardiovascular outcomes and reduce cardiovascular mortality. The glucose control is very important to control the target near normal HbA1c less than 7.0% or less than 53 millimole will decrease the macrovascular complication. The tighter glucose control initiated early in younger patients leads to reduced cardiovascular outcomes over 20 years. The thrombosis control is very important. And here is no evidence to support the different antiplatelet strategies in patients with acute coronary syndrome or coronary artery syndrome with diabetes. And at moderate cardiovascular risk, aspirin for primary prevention is not recommended, but those at high and very cardiovascular risk, aspirin may be considered in primary prevention. First of all, we can see in peripheral arterial disease, statin therapy was associated with a significant reduction of amputations and mortality compared with non-statin use. And this study shows high intensity statin, as we see, reducing amputations by 33% in high intensity statin, if compared to 19% in low and moderate intensity statins. For the mortality is the same. Reduction is very high in that about 26% in patients taking high intensity statin, if compared to the patients have the moderate intensity statin. I come to the last slide. As we see here, we can find here the clinical decision making algorithm for patients with peripheral artery disease. The approach to antithrombotic therapy in peripheral artery disease. If the patient is asymptomatic, you have to consider aspirin, particularly if disease is in another vascular bed as the coronary. For symptomatic patients, all patients should given aspirin and clopidogrel, and there is evidence for the protection of clopidogrel in those patients, or aspirin plus rivaroxaban, which is a direct oral anticoagulant. And rivaroxaban is taken by 2.5 milligram 2 times added to aspirin, reduces the major adverse cardiovascular or cerebrovascular events and major adverse limb events, but increases the bleeding, and we should calculate the bleeding risk. In recent coronary stent or acute coronary syndrome, we can find that patients are, we should give the dual antiplatelet therapy, and we have to weigh the ischemic and bleeding risk for long-term use. For revascularization, as we see here, we can find that patients have a surgical intervention should have aspirin or clopidogrel or aspirin plus rivaroxaban. And for endovascular, you have to give the dual antiplatelet for 1 to 6 months, and then it's followed by aspirin or clopidogrel or aspirin plus rivaroxaban as a new oral anticoagulant or direct anticoagulant. In high limb risk here, intensify the antithrombotic therapy, and you have to consider aspirin plus rivaroxaban, vitamin K antagonist, or dual antiplatelet therapy after bypass, and consider the prolonged dual antiplatelet after cardiovascular procedures, weigh limb and bleeding risk. In all those patients, you have to calculate the ischemic risk, you have to calculate the increasing blood risk, and taking care of the anticoagulation, prior bleeding, older age, and the chronic kidney disease, anemia, low body weight. And the limb risk increase, you have to look for the prosthetic bypass, below knee bypass, or suboptimal injury. For poor arterial runoff, extensive lesions and tissue loss, and those patients of ischemic risk have prior MI, diabetes, old age, and chronic kidney disease, heart failure, and current smoker. My take-home message here, as we see, the peripheral arterial disease is a common yet serious disease that raises the risk of heart attack and stroke. Peripheral arterial disease is not always symptomatic and may be silent in a vast majority of patients. Evaluation of peripheral arterial disease should be part of routine physical examination. Appropriate and timely interventions, medical and revascularization, can significantly improve the cardiovascular outcomes. And thank you for your watching and attention. Thank you.
Thank you very much, Professor Atef. Very clear presentation. As mentioned to all the attendees, if you have any questions, please write them on the question and answer section. We'll take all the questions at the end. So we now move to the following presentation. Please, Professor Atef, if you can stop sharing your screen. While Professor Atef is stopping his screen, I would like to take this opportunity to introduce a very good friend and colleague, Professor Abdul Khaliq Hamid, one of the eminent professors in Egypt of gastroenterology. He's also a general in the medical military, and one of the experts in the field of liver disease and diabetes and liver disease in general. So, Professor